Right, our first speaker is Dougal Atkinson from Manchester, who is an anaesthetic colleague. His special expertise is in assessing patients for major surgery, and he, while he's not a cardiothoracic anaesthetist specifically, he's got a lot of experience in assessing patients for cardiothoracic surgery. So, Dougal, thank you.
Okay, morning everybody. As I say, I'm not a cardiac anaesthetist, but I've spent the last 10 years involved with cardiopulmonary exercise testing. Now, although there's not a lot of evidence base for using CPET testing in aortic surgery, hopefully what I'm going to do over the next 15-20 minutes is provide some food for thought, and really, I guess, to show you some of the potential for using CPET testing within aortic surgery. I'm going to support the rationale for using aortic surgery with a growing evidence base in non-cardiac surgery as a whole, but some work we've done in Manchester over the last 3 or 4 years, both at Wythenshawe Hospital, which is South Manchester, and at Manchester Royal Infirmary, in patients undergoing abdominal aortic surgery, really just showing the utility of CPET testing in this patient group. And finally, just the last bit, and just to say, well, it's one thing doing the testing, how can we utilize the information we get during the testing to streamline and improve the preoperative process for patients undergoing aortic surgery? Certainly in non-cardiac surgery as a whole, fundamental to our assessment of patients is an assessment of functional capacity. This 4 METs figure comes about whether you're a true believer in that or not, but both the European guidance but also the American College of Cardiology guidance specifies 4 METs as a cutoff if you can't achieve, should be a trigger for the patient to undergo other investigation of cardiac and respiratory function. So, why CPET? Well, if you're looking at functional capacity, the gold standard assessment of functional or aerobic capacity is CPET testing, whether you're looking at Peak Vo2 or whether you're looking at Anarch Threshold. The advantage of CPET is you're getting a functional assessment which is objective for a high-risk population group undergoing aortic surgery in a fully monitored environment. There's already an established role for CPET testing in cardiothoracic surgery, which I'll allude to shortly. There's also a growing evidence base, especially here in the UK, for patients undergoing preoperative CPET testing in patients undergoing major high-risk surgery, not just in vascular and aortic surgery. But I guess the big advantage of CPET over other objective measures of functional capacity, by that I mean 6-minute walk test, shuttle walk testing, is the ability of CPET testing to hopefully identify what the cause of any exercise limitation present may be caused by, whether that be cardiac, whether that be respiratory, whether that be peripheral vascular disease. And certainly, if you're doing it in an elective setting, if you can identify the cause of exercise limitation, it offers the potential to optimize those patient conditions and hopefully reduce that perioperative risk. For the first time in the American guidance, which came out just at the back end of last year, CPET testing has a growing evidence base, and based on that, it is a Class B recommendation as something to be considered as an assessment for functional capacity in non-cardiac surgery. So we know in lung resection surgery that CPET has an evidence base, assessment of functional capacity has an evidence base, and certainly in the lung resection population, VO2 peak is somewhere between 10 and 20 is the evidence base, around 15 and certainly in the British literature and the BTS guidance. We also know it's got a strong evidence base for the assessment of patients' eligibility for cardiac transplantation. Again, large focus on peak VO2 in this setting. As well as in these settings in cardiothoracic surgery, if you look in the literature, there is some centres using it as workup for lung transplantation. We're a big adult congenital centre. We certainly use it routinely for the assessment, and hopefully as part of that to determine surgical timing in patients with adult congenital disease. And again, we use it, and again, there's not such evidence base for this, but I get a lot of referrals from the cardiac surgeons in patients with combined respiratory and cardiac pathology to help determine what we feel is the most limiting factor in terms of their functional capacity, whether it be cardiac or respiratory, before embarking on high-risk surgery. As a non-cardiac anaesthetist, when I was looking at sort of evidence-based guidance for preoperative assessment in aortic surgery, I did a very thorough literature search, and I was quite surprised to see that really functional capacity assessment doesn't seem to form part of national, international guidance for patients undergoing aortic surgery. A lot of the evidence in this section of this guidance was based on the assessment and treatment when present of coronary artery disease. There's a little anecdote, well, if you need to do further testing, there's a list of other things you can do. But certainly in the non-cardiac surgery population, we've moved away from coronary artery disease per se being the big risk factor for perioperative mortality. We know it's heart failure, and really, I guess extrapolating that to reduced functional capacity, which for patients undergoing high-risk surgery is the biggest determinant of perioperative mortality. The presence of coronary artery disease infers a slightly higher risk, but nothing in comparison to the presence of reduced functional capacity. I'm just going to quickly go over the main evidence-based parameters in CPET, because the evidence base in the aortic surgery, which I'm going to come on to, you just have to have an idea. So I don't know what everyone's experience is with cardiopulmonary exercise testing. Certainly the parameter that everyone talks about, but certainly isn't the be-all and end-all with CPET testing, is the VO2 peak, which is simply the highest oxygen consumption or peak exercise capacity the patient achieves during the test. Now, for that to be a true reflection of the patient's functional capacity, it has to be a maximal test. And therefore, interpretation of this parameter has to be done in the context of how much effort the patient put into the test. Obviously, we base predicted parameters mainly on height and age, with a small fudge factor for weight, with a normal test being above 80%. The problem with Peak Vo2, and in many ways, while a lot of the evidence base in the last few years has moved away from using it, is it is very much effort dependent. And in the frail population attending for major non-cardiac surgery, pushing an elderly lady on a bike to a maximum can be quite difficult. So a lot of the evidence base in recent years has been done, I'll just move on this one thing, on something termed the anaerobic threshold. Now, some would argue this is a better assessment of aerobic or functional capacity. And the reasons for that is it tends to occur at around 50% of a patient's peak exercise capacity. Your average patient will actually hit anaerobic threshold before they feel they've actually done very much, really. And what's been shown in the preoperative population and across populations as a whole is, unlike peak VO2, which depends on patient motivation, anaerobic threshold is not. It's therefore reproducible, and it's been shown to be the case, importantly, in the preoperative and aortic population, in the abdominal aortic population, that is. The advantage of CPET testing, again, is it's a non-invasive test. Peak VO2 and assessment of anaerobic threshold, which I won't go into, is done non-invasively without the need for putting arterial lines, etc., in the patient. And again, this is just some work by Jerry Donjou's group in Middlesbrough, just showing that A anaesthetists are pretty good at getting the AT correct, and that if a patient is reassessed in the aortic population, then that anaerobic threshold is consistent when it's done in two separate tests. Certainly in the non-cardiac population as a whole, some of these papers include abdominal aortic patients. The anaerobic threshold really has the largest bulk of evidence base in terms of determining perioperative risk. As a general rule, an anaerobic threshold less than 11 mils per kilogram per minute involves a 2 to 3-fold increase in perioperative mortality for patients undergoing major non-cardiac surgery. The third parameter, which is increasingly important and certainly has a strong evidence base in the heart failure population, is this parameter called the ventilator equivalent for carbon dioxide. Again, this is taken at multiple points during an exercise test, and is a factor of the minute ventilation at that point and the carbon dioxide production at that point. In simple terms, it's a measure of VQ matching. The higher the value, the more VQ mismatching there is. And certainly in both heart failure and the perioperative population, a value above 34 confers an increased perioperative mortality, and certainly a value greater than 42 is as probably important as peak VO2 and anaerobic threshold in determining patients at increased risk of mortality. And again, the great thing about CPET, I've just put these slides up, is it's very visual as well. Once you've got some experience about interpreting these tests, it can give you a lot of information in a very quick and easy format to interpret as well. This is a patient with significant VQ mismatching. And finally, I guess the other advantage from a cardiac point of view is you do get an exercise ECG. We know that the sensitivity and specificity of the exercise ECG is relatively poor compared to stress echoes, myoviews, etc. However, the addition of gas analysis that you get through CPET testing has been shown to increase the sensitivity and specificity of detecting ischemia. And certainly in non-cardiac surgery as a whole, Ischemia is important, especially when it's combined with reduced functional capacity. It's that patient population with both inducible ischemia and reduced exercise capacity that confer the highest peritoneal risk of mortality. Just going to go into the evidence base in aortic surgery, which is mainly UK-based actually, and again, I'm going to come to our Manchester evidence shortly. This was a landmark paper in abdominal aortic surgery by Swart and Carlisle, who are based in Torquay, and really is the first patient population in the UK where CPET and aneurysm patients were shown to have an evidence base at least. Small study in open aortic aneurysm repair, 130 patients, who they followed up for 35 months as a median from their surgery to see really whether CPET parameters were predictive of mid-term and short-term mortality. Again, mortality, let's say 7 years ago now, quite high, generally it's around 4% in this patient group. And what they found was the equivalent, so this ventilatory equivalent for carbon dioxide was the most important parameter in identifying patients at increased perioperative risk. They found that patients with an equivalent for carbon dioxide above 42 had increased 30-day mortality, but also reduced mid-term survival compared to their peers. What I'm going to come on to now is 2 papers that we've published today from combining the data set of CPET patients undergoing elective aortic surgery at South Manchester Hospital and ourselves at MRI over the last 5 years. And this is the biggest published data set looking at the value of CPET testing in patients undergoing abdominal aortic surgery. Again, we have 415 consecutive patients undergoing either open or endovascular aneurysm repair. In keeping with, I guess, national and international literature, our mortality rates were certainly comparable. We had 6 deaths at 30 days in the endovascular group, with 8 deaths at 30 days in the open group. We had no further deaths up to 90 days after those 30 days in open, although the EVAR population continued to show further deaths in that group. And what we decided to do, because it's a large database, lots of data from CPET testing, what we decided to use is to dichotomize the data, look at evidence-based parameters from CPET in the non-cardiac surgery population to see which ones, whether they correlated with poor outcome in this patient population. We use a peak of 15, which is in lung resection surgery, an aortic threshold less than 10, or equivalents of greater than 42. What we also wanted to see was there an additive effect? Certainly in the heart failure population, a combination of reduced or subthreshold CPET values confers a higher mortality risk. What we found was CPET was already being used to put patients into a high or low risk group in many ways. Patients elected to give endovascular repairs tend to be older with poorer functional capacity as determined by CPET. So in a way, we were already using CPET to determine outcomes. When we looked at these threshold CPET parameters and outcome on univariate analysis, all our CPET parameters were predictive or associated rather with an increased mortality risk at 30 and 90 days across the board. When we looked at multivariate analysis, aortic threshold less than 10.2 was associated with an increased 30-day mortality and a peak less than 15 with 90-day mortality. And for the first time, we showed the potential utility of more than one of these CPET values in predicting risk. This is the second paper we produced, and what we've done with this paper is use exactly the same data set with the same parameters, looking at whether we can predict patients' longer-term mortality, so after the 90-day mortality. And what we found is using these CPET parameters that if with increase in number of these subthreshold CPET parameters, there's association with reduced 1-year and 3-year survival, depending on the number of factors or subthreshold factors that the patient has. And again, we can see with the CPET values that if you've got 3 of these subthreshold CPET values at the median follow-up, which is just over 2 years, almost 50% of these patients have died, probably from their comorbid load. I'll have a couple of minutes left. Okay.
Yeah, you can.
I think as well as identifying patients at high risk, I think CPET has other utility as well. I think we're dealing with a high, it's more and more difficult to say no to patients, but if you have an objective measure which is evidence-based to identify patients at increased risk of mortality, it does give you further evidence base to say no in certain cases. It may help you determine whether an endovascular approach is going to be more suitable than an open approach. It may help you determine where the patient goes to, whether it be ICU or HDU post-operatively. As I've alluded to, it does offer the opportunity, if you can identify the source of exercise limitation, to optimize that patient's condition before going on for surgery. And I think analogous to that, and perhaps most important, is by identifying patient at increased risk, you've improved the informed consent-making process of that patient. You know what a cohort of patients with that functional capacity mortality is in this hospital having that operation. I'll just flick through it. CPET isn't the be-all and end-all. It's only useful alongside good clinical assessment and the use of other ancillary tests. Not everybody can undergo CPET, although in my experience of over 3,500 tests in the last 7 years, very few patients cannot undertake it. There is a small risk of morbidity and mortality according to the literature. That really is not a problem. It's a safe test, certainly in my experience. And there is an initial setup cost, but compared to many things in medicine, I think it's a very cheap test for the value that you get from it. So briefly, hopefully I've shown you some of the important CPET parameters which have a growing evidence base in the non-cardiac population. We already know that it has an established and important role in cardiothoracic surgery as a whole. There's a growing evidence of its use in aortic surgery, and as well as identifying functional capacity, it has numerous uses preoperatively for informed consent, patient optimization, allocation of scarce critical care resources in this country. So I pose the question, has CPET got a role in elective surgery? Well, I think it possibly has, and it certainly warrants further investigation and evaluation in this patient population. Thank you.
Thank you very much, Justin. Would you please be kind enough?
Yeah, have a drink. Yeah. Thank you very much. Cheers.
Please.
You're going to ask questions now? Or?
Yes,
Yeah.
yeah,
Okay.
if possible, please. Any question?
I've got one, if I may.
Yeah.
Is this? Can you hear me at the back there? Is this mic working?
Use this one.
Yeah, my question is basically we're trying to set up CPET testing in our trust for patients with thoracic aneurysms or thoracoabdominal aneurysms, and one of our concerns is sort of what happens to the blood pressure if you're pushing them on CPET testing, because when we're bringing them in to do their aneurysms, it's because we're worried the aneurysms are going to at some point pop.
Sure.
Now, I mean, we were looking on our reading at the VO2 max as being the gold standard, but you say that we can look at other parameters more safely.
I think you don't have to push patients maximally to get useful information from the test, and in many ways that's where the anaerobic threshold comes into its own. Certainly in the art, and again I'm talking through experience of abdominal aneurysms, we don't, beyond 8 centimetres we don't test them. Between 6 and 8 centimetres we do a submaximal test. We get them beyond their anaerobic threshold, but we don't push them to extremis.
Yeah.
But again, in the moment, certainly in our population, the anaerobic threshold has actually got a much bigger evidence base. So you can argue, in that case, it's the safest way of getting useful information.
And roughly how many CPET tests have you done?
Personally,
ballpark figure in your centre.
Probably about 3,500.
Any problems with them?
We've had, again, in terms of serious morbidity, it's not unusual, as in, every now and then we put patients into fast AF. We've had one patient who had a TIA within 10 minutes of finishing the test, and that's in 3,500 tests over the last, 8 years since I've been a consultant. So really, and we're doing quite complex ACHD patients with Fontan circulations, significant desaturation. So I think, we're not just dealing with the pre-op population, we're dealing with fairly severe heart failure population as well.
Thank you.
Thank you very much. John, could I ask you, what do you think, John, about this CPET test before aneurysm surgery?
We haven't used it at all in thoracic aneurysms, but it makes ultimate sense. So I'm very interested to hear your findings. I'm fascinated that you did 3,500 tests with nobody dying or having VFib or VTAC.
And again, it's very much taken up in the non-cardiac surgery population in the UK, but as a whole, I'm not aware of any significant morbidity attached to it. And again, if you read the sort of American thoracic guidance, there is this attached morbidity and even mortality, but to be honest, that's not something in my experience or from what I've read, for clinicians who do it, that is a reality.
Thank you very much, John. Could I ask, is any patient that you actually suggest should be cancelled, not to have surgery?
Again, I'm sort of slightly limited because I'm not a cardiothoracic anaesthetist. Certainly in the in the cancer surgery population. Again, the CPET is just one part of the jigsaw. You may have a poor CPET, but if it's a resectable tumour and their survival, if that resection's successful, then CPET's going to be taken into account. Again, it's really important, I think, in operations such as a Whipple, where even with an operation there's an 80% non-cure rate, and they also tend to be a fairly comorbid population and functioning quite poor. With a poor CPET and the likelihood of a good outcome being quite poor, say, then you're going to be just provide evidence to say no. I think, do we use it as that? I'd say the vast majority is risk stratification of the patients. Every now and then, the CPET is a useful adjunct to determine whether or not we do it. But I have to say, by the time they come to the CPET clinic, the ones who aren't fit for surgery are usually weeded out anyway.
Thank you very much indeed. Duke, that's your view as well?
I share that view that John Eleftheriadis expressed. I did have a question. I think the value for risk assessment is clear. You implied that you might tailor preoperative therapy to improve their status. Do you actually have data that you can achieve that?
No, that's a really good question. Completely straight, no, we haven't. It's a sort of theoretical advantage. Again, because in the non-cardiac population, they won't have input from cardiology, etc. routinely. Certainly, we have a lot volume of patients attending for pre-op assessment. We can identify the ones who may benefit from going to a cardiologist or respiratory physician. We have tried, again, there's a lot of current, obviously, controversy regarding, say, beta blockade, even in the presence of ischemia, say. We try and re-CPET test patients as much as we can after we initiate therapy. But the practicalities in terms of the number of patients, in an ideal world, we'd CPET patients several weeks before surgery. The actual reality is it's often a couple of days. So although it's the holy grail that we should aspire to, we are working towards getting patients tested earlier. I think until we're testing with good time, realistically we're not going to provide an evidence base, certainly. But I mean, say for COPD or airways disease, if you can get a patient on for just 24 hours, it can improve bronchodilation. So again, we like to think it makes a difference, but I can't provide evidence for that.
Thank you very much. Thank you.